Hi, my name is Heather Hagopian. I teach elementary PE in the Hempfield School District and have an elective PE course that I teach to juniors and seniors at the high school. This is my last course with the adapted PE program through Westchester, and it has been a great ride. My topic for this course is behavioral and psychiatric disorders in children with disabilities. The objectives of this presentation are to understand that individuals with developmental disabilities have a relatively high prevalence of psychiatric disorders, to be able to describe the types and symptoms of psychiatric disorders among people with developmental disabilities, and understand what a dual diagnosis is in relation to a developmental disability and psychiatric disorder. The overview of my presentation is to discuss that children with developmental disabilities manifest the same range of psychiatric illnesses that typically developing children do. That in addition, children with disabilities also may suffer psychiatric illnesses specific to their disability. That the presence of developmental disorder, especially intellectual, can alter the symptomatic presentation of psychiatric disorder, making the dual diagnosis challenging, and recognizing that these comorbid conditions are crucial so that the treatment can be started. When discussing the prevalence of psychiatric disorders among children with developmental disabilities, it is important to note that 1 in 7 children ages 2 through 8 years have a mental, behavioral, or developmental disorder. In contrast, 30 to 42% of children with intellectual disabilities also demonstrated psychiatric disorders, which label them as a dual diagnosis. In addition, children with intellectual disabilities have higher rates of psychiatric disorders than their peers. When discussing the causes of psychiatric disorders in children with disabilities, it is important to note that children with severe or profound levels of intellectual disabilities may have higher maladaptive behavioral disorders. These behavior disorders include stereotypic movement disorders such as receptive self-stimulating, non-functional motor behavior, self-injurious behavior, and pica. In other cases, the causes can be a biomechanical abnormality. These are conditions that affect the developing brain, such as fetal alcohol syndrome, congenital infections such as rubella, perinatal or neonatal hypoxic ischemic encephalopathy, such as lack of oxygen or blood flow to the brain, and neurobiological disorders such as epilepsy. However, the cause of most psychiatric disorders in children with disabilities is a complex interaction among biological or genetics, environmental, and psychosocial factors. It is time now for the critical thinking activity. There are a number of childhood psychiatric disorders. Can you list and name 5 or more? After completing this activity, please refer to the Psychiatric Disorders worksheet that I have attached in the email with this link. Please highlight the disorders that you can name on the worksheet and make yourself familiar with the other disorders as we will be discussing them further. An overview of various psychiatric disorders in children will be provided on the next slide when you view the video clip. So I hope that you enjoyed that video as much as I did. I found it very interesting and interactive. Let's quickly review the various and most commonly occurring behavioral and psychiatric disorders in children with disabilities, which include ADHD, ASD, ODD, conduct disorders, impulse control disorders, anxiety disorders such as generalized anxiety, panic disorder, social anxiety, OCD, PTSD, and skin picking disorder, mood disorders such as major depression and bipolar disorder, psychotic disorders, eating disorders, adjustment disorders, and maladaptive disorders. Now that we have named the most common behavioral and psychiatric disorders, let's discuss them in further detail. When discussing behavioral disorders, ADHD is the most common, prevalent neurodevelopmental and mental disorder in childhood. It is characterized by developmentally inappropriate inattention and distractibility. ASD is a class of neurodevelopmental disorders characterized by impairments in social skill, atypical communications, and repetitive behaviors. Oppositional defiance disorder, or ODD, is a disorder where the child has a pattern of negative, hostile, or defiant behavior. Conduct disorder, or CD, is when the child demonstrates a pattern of callous and unemotional behavior in which other people's rights are violated, rules are broken, and norms are ignored. Impulse control disorder is an intermittent explosive disorder in which the child assaults property and or hair pulling in order or hair pulling, and hair pulling is a disorder in which the child pulls out their hair in order to relieve tension. This could be hair on their head, or it could be eyebrows or hair on their arms as well. Let's now discuss anxiety disorders. There are several subcategories of an anxiety disorder. Generalized anxiety disorder, or GAD, is general worrying about everyday situations. Now, with this, it requires at least 3 months of excessive anxiety and worry most days about 2 or more of the following topics. So, in order to be characterized with generalized anxiety, you have to worry about 2 or more of the following, and that would be family, health, finances, school, or work. And that worrying would be over like a 3-month period. It keeps happening. It's not once or twice, it's over a prolonged period of time. Panic disorder is a physical response to stress and anxiety and occurs when one or more of the attacks includes 4 of the following symptoms: rapid heartbeat, sweating, shortness of breath, a choking feeling, chest pain, nausea, dizziness, detachment, fear of losing control, fear of dying, numbness, hot flashes, or chills. Social anxiety is a fear or phobia of school, social setting, new setting, and or the fear of embarrassment in these settings. Obsessive compulsive disorder, or OCD, is an obsession or compulsion or both. Obsessions are recurrent thoughts, images, or impulses that are experienced as intrusive and inappropriate and cause anxiety and distress. Post-traumatic stress disorder, or PSTD, is an anxiety disorder that occurs after exposure to a traumatic event in which the person witnessed or experienced an actual or threatening death, serious injury, or loss of a loved one or attachment figure. Skin picking disorder is an anxiety disorder where skin picking results in actual skin lesions and other social and medical concerns. The next type of psychiatric disorder we will discuss are mood disorders. Mood disorders include major depression and bipolar disorder. For a child to be diagnosed with a major depression label, they must have a 2-week period with at least 5 of the following symptoms not related to bereavement: depressed mood, decreased interest or pleasure in most activities, significant change in appetite or weight, insomnia or hypersomnia, psychomotor agitation, fatigue or loss of energy, feelings of worthlessness or guilt, decreased concentration or indecisiveness, and reoccurring thoughts of death and dying. Bipolar disorder consists of swings between depression and mania. In other words, extremes ups and downs. The mood disorder must have 3 of the following symptoms. If happy, there's 3. If happy, you have 3 of the symptoms, and 4 if you're on a downswing or irritable. They include inflated self-esteem, decreased need for sleep, more talkative or pressured speech. It would be noises and nonverbal children. Flight of ideas, moving from topic to topic, racing thoughts, distractibility, increased goal-directed activity, excessive involvement in pleasurable activities such as drugs, sex, or excessive shopping. Next, let's discuss psychiatric disorders or psychosis. This is a disorder that consists of alterations in thinking or perceptions that are not connected with reality. Schizophrenia is the primary psychotic disorder, which diagnosis requires the presence of 1 or more of the following 3 symptoms for at least 6 months. They include delusions such as being followed, hallucinations such as hearing voices, and disorganized speech or failure to communicate effectively. Eating disorders is another psychiatric disorder. There are 3 important types of eating disorders that occur in children with developmental disabilities. Rumination is found in infants and young children and is a disorder where children repeatedly regurgitate without the presence of nausea or GI illness for at least a month. Binge eating is a disorder where the child has recurrent episodes of eating large amounts of food during short periods of time. Lastly, pica is a disorder where the child will have a persistent craving and ingest non-food items such as wood, dirt, etc. Adjustment disorders are another psychiatric disorder found in children with developmental disorders. Adjustment disorders involve the development of the emotional and behavioral symptoms in response to an identifiable stressor. Adjustment disorders are accompanied by significantly impaired academic functioning. It can also be coupled with anxiety, depression, or conduct disorders. Children with developmental disabilities are especially at higher risk for adjustment disorders because they have limited coping skills and often have medical illnesses or require procedures that produce stress such as hospital or doctor visits. Lastly are maladaptive behaviors. Maladaptive behaviors most commonly occur in children with severe to profound levels of intellectual disabilities. Symptoms include repetitive self-stimulating behavior, self-injurious behavior such as head banging, biting hands, picking skin, etc., and stereotypical behavior such as hand waving, body rocking, and flapping. In conclusion, children with developmental disabilities are at a higher risk for developing psychiatric and behavioral disorders than their peers. In addition, children with disabilities often have dual diagnosis in which they have both a psychiatric and behavioral disorder. Early intervention and treatment are key components to identifying and supporting the child in need. Likewise, understanding and managing the psychiatric behaviors when they first begin to appear will allow the child to function and thrive more effectively and positively at home, school, and within the community. Closing thoughts and challenge. I challenge and encourage you to be the change. Keep calm and end mental health stigma and discrimination. Sometimes we all need a little help from our friends and meds. I hope that you found this presentation interesting and informative. I look forward to receiving your 2 questions. The next slide will show my references. Thank you very much.